A round of applause, please, for the International House staff who put all the microphones and the lunch together. Thank you, International House. And I also really want to offer a heartfelt thanks for the groups that provided us financial and in-kind support, which included our sponsors, which you'll see on the back of the program on the last page on the bottom, including UCSF, Berkeley, Stanford, PNHP, a big amount of support from Business for Medicare-for-All, and also from California OneCare. So thank you for the financial support that made this possible. Our next speaker is a friend of mine from college, and he's not a health guy, he tells me. He's a law professor. He teaches corporate law, torts, what else?
Corporate finance.
Corporate finance. But along the way, this fellow had a really interesting idea about how to create parallel single-payer systems, which is, on reflection, I think not a contradiction, and he's going to explain. So Dan Greenwood, thank you for joining us.
Thank you for having me. Thank you for everybody else for all the things I've learned from you so far. So Jim asked me to talk about the expand your view from the insurance-centered view that we've heard Americans all have, and to talk about a somewhat different alternative, which I'm calling the VA for All option, or America's National Defense Health System. So here's the basic idea. Rather than simply having a Medicare-for-All system that is based on the existing Medicare model with fee-for-service or global budgets, that we should also have a system, in addition, that is closer to the National Health Service model, in which providers are directly employed by the government. So the notion would be we would have two systems: one, the system using a public payer but private providers, and one in which the providers are also public employees, much like the Veterans Administration, which I'm using as a model here, or just like we have public schools and private schools in the educational system. I am assuming that for risk selection reasons, we would not be able to allow people to be simultaneously in both systems. So the notion would be that you would choose on an annual basis or something like that to which system you wish to opt into. But it would be an option, not a requirement. There would be a choice of two fundamentally different ways of running the healthcare system. One in which the institution is basically government run, and one in which just the funding is, right? So partly the motivation here is that we already have these two systems. We have, on the one hand, the Medicare and Medicaid systems, which are a national insurer and private providers. On the other hand, we have the Veterans Administration and the remnants of public hospitals, which used to be quite important, or not so much anymore, in which government employees are actually the providers. The institution is a non-governmental or governmental agency that is run like a public agency. And generally, both in the United States and elsewhere, as you heard from the international experts, both the public provider systems and single insurer systems have been quite successful. You heard the NHS is enormously popular. So are the public insurer systems. The relative success, it seems to me, is likely to depend on details of implementation and politics. And so my suggestion here is that we open our thinking to the possibility that maybe we should get the best of both systems. Rather than choosing between one of them, on some arbitrary basis to pick them both. So what do I have in mind when I talk about a public employee service provider? Something in which the actual providers are paid salary like government bureaucrats, something that is open to everyone. So not like this is definitely not the existing VA, which is open only to the veterans. I'm using it as a model rather than as a formula, right? To the extent that we want to build on the existing institution, we've got the institution, it's the VA, but this would be a major change. Open to all, compulsory for none. A competitor to Medicare-for-All rather than a replacement. The one thing that it does seem to me we ought to learn from the VA is the importance of an independent funding stream, so I would think this should be on a separate budget. The VA is thought of as part of the general defense, although it's not actually in the defense budget. I would also think of this in the same way that we thought of the highway system as part of our national defense, and suggest that it be funded quite separately from Medicare-for-All, in part so that there is a different set of constituencies, purely for political reasons. So why bother having duplication? First of all, in order to have comparison. Two systems mean we have two different ways of providing care. We can look to see which is doing a better job, and we will have automatic warnings if one of them is not doing what it should be doing. I would assume that if one system is remarkably better than the other, patients or providers or both will drift to the better one, and anybody who's paying attention will be able to see that there's a problem in the other one. Good faith administrators or legislators who are trying to improve the system will be able to learn best practices from two rather different systems, and maybe they'll learn more than if they're trapped within simply one. And conversely, when the politics are not so good, when a system is being neglected, the existence of the other one will make the neglect more visible, on the assumption that it would be difficult for a hostile administration to attack both at once. In addition, it seems to me that we ought to think and take seriously the difference between the ideals of a Medicare-for-all system and a Veterans Administration-for-all system. The incentives are quite different. So in a national medical system that is actually a provider system rather than an insurer system, providers are working as a form of national service. Their primary incentives are less to make money, not to say that people don't want to make a living, of course they do. Government work is often perfectly good work, but you don't go into government work because you want to become a gazillionaire. You go to government work because you'd like a respectable living and to serve the public. And it seems to me that patriotism and national service are very different kinds of incentives than even the incentives that the most idealistic provider is invited to have. Not to suggest that they all do, but in a fee-for-service system, you're immediately driven to think about the pay. Professionalism and teamwork, constituency satisfaction are all more direct incentives in a government-based system than they are in a M4A Medicare-for-all sector that is based on capitation or fee-for-service. Often those kinds of team incentives work better. Often good enough for government work turns out to be a lot better than what happens in the private sector. I suppose that's the expertise I actually have here, since my primary focus is on corporate governance and its failures and successes. I spent a lot of time thinking about the problems in the private sector, and it makes me think having a public sector alternative is probably a pretty good thing. It's probably a pretty good thing. Bad as the a DMV often is, it's probably preferable to dealing with your local cable company. Certainly it's better than mine. That brings me to the third major motivation for having the dual system, and that's politics. We live in an era in which the DMV, despite the fact that in most parts of the country it actually functions pretty well and efficiently, is a joke line, right, for a bad job badly done. And it seems to me that having a highly visible, clearly governmental program that is likely to be highly popular is a reminder that government can do important things today and not just in the New Deal. We can still act like the richest country in the world and not just like, I don't know, I don't want to use the word that our president uses to describe unsuccessful companies, but countries. Similarly, it seems to me that if we can get some of the ideology of the defense budget, which seems to be immune to our periodic deficit hysteria, if we can think of this as part of defense as opposed to part of social services, maybe that will give a little bit of ideological protection to the funding sources. But even if that doesn't work, at least having two different systems means that in the bad era that seems to come around every once in a while, in the bad part of the cycle, there'll be two systems to attack. Successfully weakening one might lead to stronger defenses of the other. All right? So in summary, I basically am suggesting that a choice of systems, two quite different systems, both aimed at offering medical care for all, but using a different way to get there, a different route to get there, might keep them both on their toes. In particular, government and private sector service providers tend to have different problems, right? Different failures. All systems can fail, but they have characteristics ways of failing. The characteristic way for the government to fail is through stodginess and complacency, getting stuck in a rut. It's hard to move. The characteristic private sector failure is either excessive innovation for no purpose or grift, right? Or graft, depending on which way you like to say it, which is always a problem that we have as we privatize. And so I would say having the two systems means that we maybe get less of the two diseases and have can lean on the two strengths, which again are quite different, right? The decentralized market forces of the Medicare-for-All service and patriotism planning, limited options for people who hate choices, that would be me, right? Or those who lack the expertise to make intelligent choices about their medical care, that again would be me. I'd be perfectly happy to have somebody telling me, you have to go to this doctor, because that's what happens anyway, right? But it would be nice to have it in an organized system. All right, so that's really my all I have to say, except I did think that it might be useful to trigger the conversation by at least mentioning some of the obvious downsides. Two systems, it creates duplication and complexity that has to have some justification. There might be issues moving from one system to the other, of continuity of care. There may be competition, which generally I think would probably be a good idea, but it could also lead to one system trying to cannibalize the other rather than simply improve itself. And then there are the political issues. The political issues, partially in my terminology, by referring to the Veterans Administration, which I think is incredibly important in order to point out that this isn't some foreign import from the UK, those socialist strangers over in Europe. This is actually something that we've been doing successfully for a very long time. Inevitably, I get people who go, oh, but the VA is only for veterans, and they don't know about children, and they're very male-dominated, and that's a confusion of the terminology, but it actually has nothing to do with my proposal, which is really closer to a national health service than or it's to expand the VA into a national health service. So I think I'm going to stop there and take questions. So thank you. I would love it if you would have it. Okay.
Thank you, Dan.
I have a question.
So questions.
Yes, I have a question. I'm a family physician and 19 years in private practice, last 5 years with the VA. And one of the things, I am also a 7-year vet, honorable discharge, and not eligible for the VA. So I just want everyone to know that all veterans are not eligible to be seen at the VA, only if you're indigent or retired, military, or you have a service connection. So I would love, I think this is a great plan, to expand it for all veterans and potentially their family members as well. Certainly that was a directive for the Veterans Administration to start with. But one of the other things I'm always wondered, and I'm wondering if you can answer this question, how much does the VA get paid to care for people relative to how much Medicare Advantage plans get paid for those Medicare people?
So I have no idea, but I think that Suzanne might be able to answer the question.
Hi, sorry. My name's Suzanne Gordon, and I write about veterans healthcare and helped found something called the Veterans Healthcare Policy Institute. I don't know the exact amount of the difference between Medicare Advantage. There is in the attempt to privatize the VA now, there is a plan afoot funded by the Kochs to create Veterans Advantage plans. Yeah, so this is the next thing coming down the stream. But the VA delivers care because of what you mentioned, because not everybody's eligible. It's only the sickest, poorest, and indigent who are eligible, and they deliver care to the most difficult and complex patients for less costs than in the private sector. And all the studies show that VA care is equal or superior to the private sector. I just wanted to make a comment. Thank you for recognizing me. I'm not sure what I think about Dan's exact proposal because I haven't seen it before, but I think that in groups like this, we really need to think a lot about, because we're always looking to Europe and Canada, but we have a homegrown national health system in the United States. It should cover all veterans. It doesn't. Should cover their families. Doesn't. But everything I've listened to in the past couple of days, you know, we say we want more transparency, we want geriatrics, we want home visits, we want coordinated care, we want long-term care, we want reasonable pay for CEOs, we want reasonable pay for physicians, we want transparency, we want social determinants of health, et cetera, et cetera, et cetera. You got it in the VA. And the reason why they're demonizing the VA is the fundamental reason the Koch brothers have spent $52 million over the past 4 years to fund the Concerned Veterans for America is because they want to kill Medicare-for-All. They do not care about health care. They're not in the health care insurance business.
Suzanne, let me interrupt. This is extremely helpful, but I want to give other people a chance to ask questions.
Sorry.
So who's next? Who's got a microphone?
Hi, Mike Huntington from Corvallis, former mad as hell doctor, still mad as hell. And Oregon just completed a survey done by the Elway Institute on Seattle. And in keeping with what your proposal is, surprisingly, 75% of the respondents favored the idea of a universal health care system. 62% would pay 2 to 3 times their current state tax in order to be freed of premiums, deductibles, and surprise bills. And more pertinent to your comment is that they would accept a publicly operated system, not just a publicly insured system.
Okay, I think there was no question there. Up front here, do you have a question?
So my question is, I think bringing up the DMV is a great point. And one of the things we haven't talked about is the desire of people in upcoming generations to work for the government. And I think that that's something that was sort of brought up there. But what do we do to make it attractive for millennials, younger, people in Gen X to go into government to help with some of this that will need to be done and the bureaucracy piece when it's not very attractive right now?
I think the notion of serving the public is and always has been very attractive to a large number of people. When you spend a generation saying that people who work for the government are sucking on the public's teeth, right, and are not serving the public but exploiting the public, it gets harder to convince people that this is actually service. But that's part of the motivation here. It seems to me that we need to make government work respectable again. We need to say to people out loud, money is not our only value. We also value the community.
We have time for one more question before switching to the upcoming panel. So who has a microphone and wants to ask that question?
I'm Deborah Palmer. I'm a nurse practitioner, and I wanted to ask a question about doing the same thing with the National Medicare-for-All that the VA did, and that is removal of barriers to full scope of practice for nurse anesthetists and nurse practitioners within the VA. Do you think that would be something for the Medicare-for-All plan that you propose happening at the same time as a VA option?
Go ahead.
I think this is a question for somebody who's more in the weeds than me. So is there?
Okay, we'll give Suzanne another chance, and then we're going to, just a quick response, and then we're going to break and quickly go to the next panel. Suzanne. Can someone give her a microphone?
They've done that in the VA, and I think that also, I mean, it's something that people could consider in a Medicare for All plan. It would certainly get nurses, and nurse practitioners even more engaged in this discussion that they already do. And the VA, the VA's rules supersede state rules.
Well, thank you very much, Dan.
Thank you.
And Suzanne.